Good morning. Still the morning for a few minutes. We'll begin slightly in advance because indeed the room is fully packed and I don't think that people can still enter the room easily. My name is Daniel de Backer from Brussels. My colleague is also well known, is Jean Witeboul from Paris. And we will be very delighted to discuss with you the fluid responsiveness. And so, Jean-Louis will begin with 2 or 3 slides, and we will ask you a lot of questions because this is deemed to be interactive, so we count on you for that.
Thank you, Daniel. Good morning for a few minutes, as you said. In fact, it is very simple. We want to discuss, to debate with you, and the 4 questions I put here are, I think, the main questions about fluid responsiveness. The first one is, what is? Why? Why we talk about this? Well, there is this demonstration box here. When? And how? So, rapidly, what is? You know, just physiologically, it is defined as the capacity of the heart to significantly increase its stroke volume or cardiac output in response to a volume challenge. Could be fluid, could be a preload challenge. And just, I don't want to bother you with physiology, but this is my only slide with physiology. This is a famous Frank Starling mechanism with stroke volume on the y-axis and preload of the ventricle. Could be the right, could be the left. And you know, the shape is like this. It's not linear, but curvilinear. And we like to define 2 parts, but in fact, there is no 2 parts. It is a continuum of parts. One is preload responsiveness condition, meaning that if you increase preload by giving fluid, by whatever you want, you challenge preload and you increase preload. And if the ventricle is working on this part, which is a normal part, which is physiological part, stroke volume increases and cardiac output should increase. And this is the definition of preload responsiveness of the ventricle. If you increase preload by whatever you want, fluid for example, and there is no increase in stroke volume, we call this condition preload unresponsiveness. This is valid for both ventricles, and fluid infusion, for example, will increase the left ventricle stroke volume only if both ventricles are preload responsive, and therefore I like to say that fluid responsiveness is equivalent to biventricular preload responsiveness. This is a clinical concept, this is a physiological concept. So this is for the first part. If you have questions about this is physiology. I think that more important is to talk about the other questions. Why? I have no slide. Why we do this? Do you have an idea why we assess with fluid responsiveness in critical patients? Is there a reason? So maybe 2 reasons?
Several reasons. And so, who wants to begin answering this question? I think you are multiple here, so you are interested in the domain, so you should be having your ideas. Because, well, the first obvious reason was all patients do not respond to fluids. I mean, that's just, you have 2 parts at least of this relationship, so that's one thing. This is the most important aspect.
This is the most important reason. Not all patients are fluid responsive. For at least 2 reasons. This first, because many times they already receive fluids, and therefore, if I go back to this, they already increased the size of the ventricle, if we want to be simple, and they would be on the flat part of the relationship. The second reason is that maybe there are some cardiac dysfunction, an abnormality of contractility, for example, and therefore they are very, very fast on the flat part of the relationship. And sometimes we have the combination of the two reasons.
A third one could be that we all know that there are risks associated with fluids. And if you have a test, not all tests, but if you have a test that can calculate or compute what are linked with the magnitude of the changes in cardiac output after when you give a volume of fluids, then this begins also a very good way to, let's say, compute the risk benefits a priori. You can also still admit that perhaps when you will give the fluids, you may have more adverse events that are not totally depicted at baseline. But given the associated risk at baseline, you need to ensure that you have a very good increase in cardiac output after. Because indeed, remember that if you are here, you will have a major increase in cardiac output with a minimal amount of fluids. If you are here, well, you have nothing. But if you are here, you begin to have some increase in cardiac output with the same amount of fluids. So this means that when you are predicted to have a 30% increase in cardiac output, well, this means that the benefits associated with the intervention are quite valuable. If you have a 15 or 20% increase, well, still can be interesting, but then everything depends on the price you pay.
Exactly. And because when a patient is fluid unresponsive or a little bit fluid responsive, is on this part of the curve, and there is no or a little increase in cardiac output, but there is a risk of increase in the filling pressures of the ventricles. The left ventricular filling pressure for the left ventricle and the right ventricular filling pressure for the right ventricle. And therefore, if you have an increase in the filling pressures, you have a risk for the left ventricle to have an increase in the risk of pulmonary edema, and for the right ventricle, you have an increase in the CVP and all the pressures in the veins with a risk of venous congestion, edema of the tissues or the organs, etc., upstream. So this is a risk. So if there is no benefit, there is a high risk. If there is a high benefit, normally there is a low risk, except if there is some alteration of the permeability of the capillaries, of course, and therefore you have a risk. And this is always a benefit-risk balance to assess before giving fluid. And one way to assess the benefit is to perform fluid responsiveness test in order to have an idea what could happen if you give fluid.
So that's the prediction of the fluid responsiveness. And of course, when you will give volume at some point, it's important to then assess the response to fluids, and that will be the fluid challenge. The fluid challenge is not a way to predict the response to fluid. It's just a way to assess the response to fluid to ensure that first, well, you did not have an error in your prediction and your patients still respond to fluid. And the second one is also to evaluate the tolerance to fluids by several means you have at the bedside, because indeed, sometimes, you don't look at the diastolic function with the test. You just see that, yes, I give the volume, I will increase the cardiac output. But when you give the volume, you increase indeed the cardiac output, but the diastolic pressure may increase, and then indeed you have these POPs that increase, and perhaps it's time to stop at some point, because indeed the tolerance to fluids begins to be a bit on the edge, and even though you may respond to fluid, it's not a good time to continue. So that's perhaps when we need to move to the next question. By the way, we begin to have this on the when. And that's
when to do this? What is your opinion? For example, you have a patient arriving at the ICU or in the emergency department.
More in the emergency department, because we have this surviving sepsis
in the ICU.
There.
What do we do? Is in shock. What do you do? Do you assess fluid response? Septic shock, for example, which is simpler. What do? Do you assess fluid responsiveness, or do you give fluids first?
You give fluids.
Yeah, it is better. Yeah,
because So there is a low probability that the patient will not respond to fluid because indeed this patient is relatively naive. I mean, he doesn't have received anything there. But of course, everything depends on your healthcare system. If you have a healthcare system with ambulances and this ambulance has to travel the traffic jam of Paris and is stuck in at 200 meters from his hospital, but is stuck there and the physician is giving 1 liter, 2 liters, and then the patient arrives in the emergency department, well, the patient already has received 2 liters. Will this patient be fluid responsive? Maybe not at that time. So if you have indeed a scoop and run system, when the ambulance have done nothing and they lift you a patient in the ED, this patient, yes. I mean, because indeed, often these patients do not eat, do not drink. These patients have some insensitive losses, temperature, increased capillary leak, whatever. All these factors make that these patients have some degree of hypovolemia to begin with, and these patients will respond to fluid. But then the question arises, at some point they have received something. And then, because we saw this starring relationship, are we still on the left side, or are we more on the middle side, or even on the right side? So this begins to be one of the issues there. So basically, it's when the patient has received some amount of fluids that the patient is more questionable for the response.
And if the patient has some comorbidities,
exactly,
it is indeed, if he receives, for example, 10 ml per kilogram of crystalloids, 10 ml per kilogram, if he has also cardiac dysfunction, maybe you have to be very careful and to test. You have to test fluid responsiveness because you don't know. And again, if this patient has some cardiac dysfunction and you give fluid and he's not fluid responsive, it will increase, probably, it will increase the left ventricular or the right ventricular feeding pressures.
John, we have data on that. I mean, not yet published, so maybe you can ask, what is the overall amount of fluids that you can receive before being unresponsive to fluids? Because I think that's an important question.
Yes, we did a study, but not yet published, so this is an abstract we presented in the last Isicem meeting in Milan. And we had now 140 people, patients with septic shock. And we started to test fluid responsiveness at the beginning. It is a study. It is a clinical study. And when the patient arrives, naive of fluid administration before, and we tested regularly fluid responsiveness, and we calculated the volume of fluid the patient received before becoming fluid unresponsive. And we had a big surprise. No, it's not a surprise for me, but some patients become fluid unresponsive after 10 ml per kilogram, maybe because they were not very dehydrated, hypovolemic, and also maybe because they had some cardiac dysfunction or diastolic dysfunctions, for example. And some patients became fluid unresponsive after 100 ml per kilogram of fluid. 100 ml is a lot. These patients more likely had abdominal sepsis or peritonitis or something like this and fluid losses. And of course, this patient need a lot of fluid. But the other ones, no. But what we observe is that never, when the patient arrives, the patient is fluid unresponsive before receiving 10 ml per kilogram. So I think that 10 ml per kilogram is safe, but after 10 ml, maybe you have to test fluid responsiveness. If shock persists, if shock disappears, okay, it's good. There is no need to continue, of course. But if shock persists and you gave 10 ml per kilogram, it is time to reassess and to perform tests.
Is there any interest to do a test on day 5, day 6, or day 7 when the patient is stabilized? I mean, the patient is under stable doses of vasopressors, is on mechanical ventilation for 3, 4, 5 days, and then the patient is there, lactate is normal, capillary fill time is normal. Do you see an interest to perform the passive leg raising test or whatever test at that time? Well, there could be an interest there. Because at that time you are beginning to think, well, I've given 6 liters or 7 liters since the patient is arriving in the ICU, and the patient did not really expel all these. So there is a positive fluid balance. Maybe it's a good time to think at giving diuretics or giving, if the patient is on renal replacement therapy, even worse, I mean, to begin to have some removal of fluids. And when you want to remove fluids, the best way to know if your patient will not be not tolerating the removal of fluids is also to look at these tests. Because indeed, if your patient is still fluid responsive at that time, maybe it's not a good idea to give volume because, again, no problem, it's tissue perfusion, whatever. But nevertheless, it will not be a good idea at that time to withdraw volume because then you can transform a stabilized patient into an unstable patient with hypertension and low cardiac output. So these tests may still be valuable at the later stages, but then not to indicate to give volume in most cases, but to withdraw volume in these cases.
Exactly. And if, for example, the patient is fluid unresponsive after some days, they have some pulmonary edema or positive fluid balance, and if this positive fluid balance impacts some organs, like pulmonary edema or some other organs, maybe you can think about removal, fluid removal, and you can use this kind of test. If the patient is fluid unresponsive, okay, you can go. If you have hypoxemia, if you have acute kidney injury, and you think that this is maybe due to some venous congestion or pulmonary pulmonary vein congestion. Okay, maybe we can go to the last question. But if you have questions right now, it's time. You know, we live in a few hours, in a few minutes. If you have burning questions about all these issues, when, why, you are very shy.
Okay, so now how? How to assess fluid responsiveness? So
yeah.
There are several ways to do it, and I guess that many of you may have some ideas. So
what we know now, and this is the slide, we know that it is better, if you want to assess fluid responsiveness, to use some dynamic tests, dynamic measures, and not what we call static measures of preload. For example, it's difficult to use CVP to predict fluid responsiveness, except if CVP is very, very low, or very, very high. But in the majority of cases, our patients have a CVP between, I don't know, 8 and 12 or something like this, and you cannot know what to do. So this is why all the international societies and the national societies recommend to use dynamic tests. What is a dynamic test? This is something which can quantify the slope of the Frank-Starling curve at the time you decide to give a treatment, or to give or not to give. And how to determine a slope? You need at least 2 points. You need to change preload very quickly and to look at the simultaneous changes of stroke volume or cardiac output. So to do this, you have to be very quick and with some procedures which modify preload challenges. Okay, you understand this? But you need to assess, of course, the response of cardiac output to this preload challenge very quickly with some devices, and we can discuss about this, of course. Okay, this is very simple. Very simple. This is the principle of dynamic tests. We have 2 categories of tests. If the patient is mechanically ventilated, we like to use the heart-lung interaction test or indices. And if the patient is not mechanically ventilated, we can use a passive leg raising test, but we also can use a passive leg raising test in patients who receive mechanical ventilation. Okay? How many of you use a PLR, passive leg raising? Okay. Who use some heart-lung interaction indices? when the patient is mechanically ventilated. Yeah? And the others.
Who use the mini food challenge? Okay.
So again, the mini food challenge is preload challenge, but you need to give a small amount of fluid, of course, not to overload the patient.
What is the problem with the mini fluid challenge? Is that I'm giving some volume and I increase the cardiac output. And then I guess that with what I have done, I can predict the first response to fluid. Well, be careful, because it's not so straightforward, because you see the curvilinear aspect here of these curves. And so if I increase here my preload by this, in this patient, yes, probably the next time it will still increase the stroke volume. In these patients here, if I give here 100 milliliters, I increase here. If I give another, maybe this will not increase anymore the cardiac output. So be careful, because the tests in the studies were flawed, because they looked at 100 milliliters to predict the response of the total 500 milliliters. But of course, the 100 milliliters were taken into the computation. So of course, if you already respond to 150 milliliters or to 100 milliliters, by definition, you are a fluid responder. But it doesn't mean that this response to 100 milliliter will predict the response to the next to 100, or the next 100, or the next 100. So it's a good way at some point to stop when the patient will not respond to fluid. Yeah. But basically, it's a fluid challenge. It's not predicting the first response to fluid. Otherwise, my classical fluid challenge of 500 milliliters, let's say, would predict the response to the next 500 milliliters. And we know this is not true. So indeed, this is just a conceptual bias. The real value of the mini fluid challenge is that you give a relatively minimal amount of fluid, and once the response is no more observed, then you can stop.
Exactly. This is, in fact, a test to stop.
Yeah.
More than, yeah, I fully agree. Yes.
For the mini fluid challenge test, how much is the possibility that I will not detect the effect that
That's a good question.
that is too small?
Because by definition, if you give a small amount of fluid, it cannot increase cardiac output a lot in general. So in the meta-analysis about fluid challenge, mini fluid challenge, the cutoff value was around 5%. 5%. 5%, you need a very precise technique to measure cardiac output. For example, you cannot use thermodilation because the precision of the technique is not enough, is not good enough. You cannot use echocardiography and velocity time integral. 5%, it is in the limit of the variability of the technique. So you need to measure by a very precise technique. For example, pulse contour analysis could work for this. Maybe we have 6 minutes left.
A bit more.
But it's okay, because we can stop at 12:15. Okay, so you have
8 minutes.
8 minutes. Okay, so I said there are two categories. The idea behind the heart-lung interaction in this, the idea behind, I don't want to go into detail, is that the more the cardiac output, or the more the stroke volume changes with mechanical ventilation, the more likely the patient is pleural responsive. This is the general idea behind. I don't want to go into detail because this is, but you know this, I think. So we have different indices. We have the respiratory variation of stroke volume, which could be approached by pulse pressure variation or stroke volume variation if you use a monitoring device which displays the value of stroke volume variation, pulse contour analysis in general. And pulse pressure variation is the change during mechanical ventilation of the pulse pressure. Do you know what is the pulse pressure? Yes, you know there's a difference between the systolic and the diastolic pressure.
There's a difference between the diastolic and the next systolic.
Yeah.
That's
Okay, but this is
it is
the
a
difference
eruption
between
of
the
the
both.
stroke volume inside the.
Yeah. That's the difference. It's the difference between the value of the systolic, the value of the diastolic. Why we use this? Because pulse pressure has two main determinants. The first one is stroke volume, and the second one is arterial stiffness, compliance here, stiffness or compliance inverse. And if we assume that stiffness does not change during the mechanical ventilatory cycle, we can assume that the changes in pulse pressure reflect the changes in stroke volume. Okay? And this is simple because you don't need any cardiac output monitoring device to do this. Okay, this is the principle, high PPV. We can assume in some conditions, I will go back to this later, not later, just after, that it is associated with periodic responsiveness when you have a low PPV associated with periodic unresponsiveness. This is the hypothesis, and this was demonstrated in many studies.
Before you jump there, I mean, do you see one situation where the pulse pressure variations will not reflect the stroke volume variation? So even though you have stroke volume variation, the pulse will not markedly change. It's because you have a very elastic aorta, and when this occurs, mostly in very young children. So for those of you who are dealing with pediatrician patients, be careful because you may miss it, while the stroke volume variations still remain valid in these patients. So with adult patients, and so even with 18 years old, the artery begin to be a little bit more stiffer. So indeed, then you can have it without any problem.
So this is one of the first study, in fact, which demonstrated that pulse pressure variation was very good to predict for responsiveness compared to CVP and the wedge pressure in this study in septic shock patients. Okay, so.
But the more important aspect there in that trial was not only it was predictive, but also the higher the pulse pressure variation, the higher the change in cardiac output after.
Yeah.
This is really very important because, again, in some patients who are up to 40-50%, these were really very high.
This is very important. In this study, we found a cutoff of 12-13% for PPV. Above 12%, the patient increases cardiac output by more than 15%. Okay, and less than 13%, less than 12%. It was considered as fluid unresponsive. Nevertheless, what is important is the degree of fluid responsiveness. Your action or your reaction should not be the same. If PPV, for example, is 30% or 14%, you can expect a higher increase in cardiac output, and therefore this is very important for your decision to give or not if you consider the risk of fluid administration. This is important to assess the degree, not only the presence of fluid responsiveness. But the issue is that we have a lot of limitations of PPV. In particular, in ICU patients, when you ventilate the patient with a low tidal volume, you have some false negative cases. When the patient has some spontaneous breathing activity while mechanically ventilated, it does not work very well, increased abdominal pressure, etc., etc. So we have limitations, and in particular, low tidal volume. So there is a possibility in this case is to perform a tidal volume challenge, which consists in increasing tidal volume from 6 ml per kilogram, for example, to 8 ml per kilogram, and to look at the change in pulse pressure variation, simply the change in pulse pressure variation. And in this study, we showed that, in fact, when you look at the difference between the value of PPV measured at 8 and the value of PPV measured at 6, simply the difference, when it is more than 4%, you can assumes that the patient will respond to fluid administration. When it is less than 4%, 3%, for example, you can assume the opposite. So this is also interesting in my experience, because I use a lot. For example, some patients, and I saw this in COVID ARDS patients, I saw this when we perform a PPV, tidal volume challenge, PPV sometimes went up to 12, 14%. And the patient was really very fluid responsive. It does not mean that you need to give fluid. It depends on the risk, of course, and you have to balance the risk. Okay.
What is the false positive that we may have with the test here? Normally, you have excluded it with echo before, but it is acute cardiopulmonary. Because indeed, in these conditions, if you further increase the tidal volume, you will, of course, further increase its variability. So it's a minimal risk because it occurs in some patients, but normally you have performed the echo before, and that's why the beauty of this aspect is that when you have ruled out the acute cardiopulmonary, these tests are really quite strong and valid with all these way to handle with the low tidal volume.
This is an example, but maybe I can skip this. You understand the principle, because we
have 1 minute left. Do you wish to see perhaps the passive leg raising test? I think that's probably...
We have 1 minute.
1 minute,
right.
yeah. So I think that the most difficult aspect, I think, to discuss with the people, because the others are more obvious.
Yeah. Passive leg raising test, so it is feasible in patients who receive or not mechanical ventilation. So this, you move the bed of the patient, and it mimics a free challenge, because you mobilize some venous blood from the lower part of the body to the upper part of the body and to the thorax, and you mimic a free challenge. And of course, you need to assess the response to PLR to predict fluid responsiveness, of course, and you need a real-time measurement of cardiac output. Again, you cannot use transperimeter mode dilution because it is too long. You need to average 3 measurements, etc., 3 bolus injections.
To evaluate the effect between baseline and maximum 1 minute later.
Yeah, 1 minute.
This means that you need to have a rapid response measurement.
This is an example. So the patient was in this position, semi-recumbent position, and we move the bed. This is an automatic elevation by pressing a button. And first, there is elevation of the legs, and then the trunk and the head are horizontal. And we looked at the change in continuous cardiac index here, 1.47, very, very low. And we look, 1.47 was the baseline value. Now it is 1.53, 54, 55, 56, etc.
And one important factor is that their pressure transducer is, of course, fixed with the bed. So it needs to move with to remain at the same position, reflecting the right atrium. Otherwise, you will have errors in your measurements, of course.
So the maximal was 1.59. I think the patient probably was fluid responsive. I did not calculate, but probably it is more than 10%. But look, this is the extracellular water in this patient, 27, which is a very high value. So we have to balance the risk of giving fluid. We know that the patient will respond, 1.6 now, 1.60, but we have a risk. So we have to balance this. If, for example, PLR increases cardiac output by 30%, I will go to give fluid. Here, 10%, or I don't know, something like this, it is maybe risky.
I never say it depends on the other condition. If
It
the
depends
patient is
on
on
the condition.
major doses of vasopressor, vasoconstricted, maybe it's valuable. And with a lactate of 10, if your patient is not so bad on
this is another example, sorry. 191, and it goes up to look a lot of increase. So and in this patient, lung water was 9. So you are more comfortable for the risk of pulmonary edema. And I think that if the patient is really in shock, it was 190, so probably he was in shock with a low signs of shock. And in this patient, I would not hesitate if the patient is in shock to give fluid because he is a fluid responder with a less risk of pulmonary edema.
So John, it's time to stop, unfortunately. Yeah. So just one thing there, you need to measure the cardiac output. You can measure it with this technique. You don't rely on changes in blood pressure. These are not reliable. You can perhaps look at the pulse pressure variation changes, but this is a little bit...
in the example, I did not notice, but...
You can use in this ventilated patients the end-tidal CO2, but the changes are relatively minimal. It's 2 or 3 millimeters, so it's not always that easy. The best is, of course, like this. You can do the echo, but again, with the echo, you need to be sure that you did not change the probe position during the movement, which is not always that easy, of course.
Yeah.
Okay, so thank you very much.